Hi, my name is Kylie Brubaker, and I'm going to be going over cardiac murmurs. I think the first good question to ask when going over cardiac murmurs is, what's the point of identifying them? And one of the biggest things I think is it's a clinical way to identify any heart valve abnormalities like stenosis or regurgitation. It can also be a way to indicate things like valve calcification, endocarditis, and rheumatic fever. So valve calcification can occur with age as the valves become narrowed or stenotic. Endocarditis occurs when there's bacteria present in the lining of the heart or its valves, and this can damage the heart valves if it goes untreated. Rheumatic fever can also affect your heart if it isn't treated properly as well. Some clinical scenarios that I see this being indicated is in pretty much all clinical scenarios. It's common to listen to heart sounds even as part of a focused assessment for another body system. But specifically, people with a familial history of a heart defect or hypertension, hyperthyroidism, endocarditis, pulmonary hypertension, lupus, and rheumatoid arthritis can be an increased risk for problems with their valves. I personally work on a cardiac unit, so we listen to patient heart sounds every shift and are charting or reporting any unusual findings. When listening to heart sounds, there's 4 specific places that you want to listen to. The aortic valve is at the second intercostal space on the right side, and then the pulmonic valve is the second intercostal space on the left side. Tricuspid valve is left lower sternal border, and then the mitral valve is the 5th intercostal space in the midclavicular line. Okay, on the right side, second intercostal space, that's the aortic. Then the left side, second intercostal space, the pulmonic. Then down the left sternal border is the tricuspid. 2, 3. 5th intercostal space, midclavicular line. And then back through with the bow. And then you can have him lay down on his left side and listen the same way, or lean forward and breathe out. So when you're listening for the S1 and S2 heart sounds. When you're listening as well, you want to listen to the rate and the rhythm at which the heart is beating. So it's important to know what normal sounds like so that you can identify the murmurs and the things that are abnormal. S1 means that systole is beginning, which is caused by the AV valves closing, and that's the tricuspid and mitral valves. And that's the loudest at the apex of the heart, so the bottom part. And then S1 is the lub in the lub-dub. Another way to know that you're hearing S1 is to feel the carotid pulse, and then listen at the apex of the heart, and the S1 should coincide with the carotid pulse when you feel it pulsate. S2 is heard loudest at the base of the heart and is associated with the closing of the semilunar valves, which are the aortic and the pulmonic valves. As I said before, S1 and S2 are completely normal findings. So when a murmur is auscultated, you can hear a blowing, swishing sound, and this is due to turbulent blood flow throwing through the heart and its valves. Some murmurs can be innocent, where they're not going to cause a problem, while others can be abnormal. Murmurs are classified and identified by their timing, loudness, pitch, pattern, quality, location, radiation, and posture of the person or the patient. Murmurs can be caused by congenital defects or acquired valvular defects. So when we go to identify murmurs, they can be identified whether they're early, mid, or late systole or diastole. Systolic murmurs can be heard in normal hearts, or they can indicate heart disease, whereas if you hear a diastolic murmur, it always indicates the presence of heart disease. So as I said before, there's different ways that we classify murmurs. To start with, how loud they are, we do that by grading them 1 to 6. So a grade 1 murmur is barely audible and is heard with much difficulty, whereas grade 2 is a faint murmur, but it's clearly audible. Then you have your grade 3, where it's easy to hear. A grade 4 is loud, but it also has a palpable thrill on the patient's chest. A grade 5 can be heard when part of the stethoscope is lifted off of the chest, and then the grade 6 is loud, and that can be heard when the whole stethoscope is lifted off of the chest. Then, moving on, you have your pitch. So your pitch can be low, medium, or high, and this changes depending on the rate of the blood flow that's flowing through the heart. Another way is the pattern. So the pattern of a heart murmur refers to the intensity of the murmur. This takes practice, and it can be pretty difficult to identify, in my opinion, because of how fast murmurs occur. They can get louder, which is referred to as crescendo, and then there's other times where they can taper off, and that's referred to as decrescendo. There's also the combination of both, where it's going to get louder and then quieter, and that's crescendo, decrescendo. Then there's the quality of the murmur, and that refers to whether it's blowing, it's harsh, it's rumbling, or it's musical. So it can have different tones and sounds to it as well. The location is described where the murmur is heard the loudest, and this can be done through the valve area or intercostal spaces where the loudest murmur is heard. Then there's radiation. So a murmur can be heard other places rather than just at the valve spots. It can be heard in the precordium, the neck, the back, or the axilla. Some murmurs get louder or disappear depending on the patient's posture. So that's what the patient's posture has to do with it. If you roll the patient to the left side and listen with the bell at the apex, you can listen for that. Or you can have them sit up, lean forward slightly, breathe out, and then you can use the diaphragm. And then aortic regurgitation can be identified in this way. As far as innocent murmurs, they're commonly grade 2 or lower, mid-systolic. They're short, they're crescendo, decrescendo with musical qualities, and they also commonly disappear when the patient is sitting.